for a Q&A session afterwards. It is about 4 o'clock in the morning for him currently in Canada, so we'll cut him some slack for not turning up to give the lecture. So thank you, and we'll over to the tech people.
Okay, well, it's a real pleasure to join you, albeit virtually, for the talk today. I know that you've already had a great set of talks this morning, and I'm looking to build on this, what should be a very interesting discussion on placebo effects as it relates to hopefully all of your practices in the room with regards to neuropsychiatry as well as clinical research. So, as you may have already heard, I'm a neurologist specializing in neuropsychiatry back in Toronto here. And really, this is a topic that's near and dear to my heart, so I hope you found it interesting today. I don't have any relevant disclosures for this talk. My research is supported from a variety of sources. I do have a few relevant affiliations, and those would be the Harvard Program on Placebo Studies. I'm one of their research team members, as well as I am the placebo effects co-lead for the Pan-Canadian Neurotechnology Ethics Consortium. So really today, I hope to give you a pretty wide kind of sampler platter of the field, starting with some introductory principles, going into how placebo effects are interacting in medicine, then a bit of a shift to more kind of the research setting, and then coming back with kind of a sense of where do we go from here, especially in the lens of neuropsychiatry. And then, of course, there's my secret objective, which is to make you feel like a kid in the candy store, because the first time I was really exposed to this topic, I certainly know that I felt that way, and I hope it's thought-provoking for everybody in the audience. So, as you've heard throughout this conference and previous conferences, you know, there's a million of these lines connecting neurology and psychiatry. It's really arbitrary divides between these fields. And there's a few disorders that might kind of characterize this interface, maybe traumatic brain injury, functional neurological disorders. This topic of placebo effects is really a phenomena that I also believe fits smack dab at this interface between neurology and psychiatry. And so I had no intention on going into a career with any focus on placebo effects whatsoever. And it really all began when I was down in Boston doing my fellowship training. And I was down there to do a fellowship primarily in brain stimulation with world leaders in the field. And when I was down there, I was asked to author a really comprehensive textbook chapter that looked at all the studies kind of to date in different clinical fields. And I was just blown away by studies like this that we talk about at our rounds. And this was a large, and I believe it's still the largest recent randomized clinical trial, sham controlled of TMS for depression. And this study was done in the veterans hospitals in the US, and really some treatment refractory patients with a lot of complexity, PTSD. And they found that TMS had a remission rate of 41% of patients getting TMS went into remission on their Hamilton's kind of scale score. But amazingly, 37% from sham or placebo also went into remission. These are treatment refractory depression patients, and I couldn't believe when we were talking about the study at our kind of journal club that nobody was really talking about the placebo effect aspect. Obviously, this trial was a negative trial, and they were humming and hawing about different, methodological variables. But I just couldn't believe it. And as a doing my core training in neurology, I'm not, this was a different foray into psychiatry trials. So I'm like looking at some of the neurology trials, including one of TMS for stroke recovery, and similarly shocking findings of 2/3 of patients getting a sham device met kind of the improvement cutoff criteria on motor functional tasks. And I really, some of these results were so shocking that the company actually said there must be something active about the sham coil that we have, and we're going to do another study with a different sham. But lo and behold, they found the exact same astonishing results of these massive improvements. And this is the kind of the press release on those unfortunate study, and the company just kind of just shut off all operations in this field. And that was kind of a hold the phone moment here. I'm just like, okay, why is nobody talking about this really in our fields of neuropsychiatry and neuromodulation? I think there's really a bigger story, because all the coverage that I was seeing around placebo effects, at least in major kind of lay and mainstream science media, was about kind of the negative nuisance aspects of that side of things, not at okay, let's interrogate this a bit more and see maybe how we can use it for benefit. And so that's where I did a major pivot in my early career. And thankfully, Ted Kapchuk, who's the head of the Harvard program placebo study, was just down the hall at Beth Israel in Boston. And we started doing a lot of collaborations. And he's a leader. He's been in this field for a very long time, and really took kind of my research career in quite a different direction, and kind of why I'm here and chatting with you today. So just to make sure we're all on the same page, and I'm mindful of time here, I believe I have about a 50-minute block where want to leave at least some time for questions. So I'm gonna fly through a bunch of slides. Certainly can answer more questions down the road to go into some more details. So we all have heard the term placebo effect many times. It has nothing to do with the inert pill or sham device. It has all to do with the therapeutic context which is being created. And this is a complex interplay between internal factors, someone's emotion, someone's expectations, someone's beliefs, and external factors like treatment cues, the patient-physician relationship, innovation, intensiveness, etc. And the field has changed in many ways, but these were the first studies that really turned placebo effects from some mystical phenomena to something embedded in science. Where it was in the early 2000s where they saw that when patients got a placebo, when they were in a functional imaging scanner, they saw activation of brain regions that looked similar, including the anterior cingulate, to when patients got an opioid analgesic. And so that was a huge foray in the pain field. And then similarly, in the Parkinson's field, they saw changes in the brain reflective of dopamine release when placebo was given. And we've obviously come a long way now from some of these initial big studies. We see a variety of brain regions that get activated or deactivated with placebo effects. Most notably, we see activation of expectation regions in the frontal limbic circuits. We see activation of reward centers in the ventral striatum, and we see reduction of pathways involved in the fear stress response circuits. And you see all these different regions. You're thinking, hey, network neuroscience, these all must relate to networks, and they do. And this was some of the work recently put out by our group in Boston, looking at which networks are changing, and certainly it looks to fit some of these network models that we're seeing more and more of. Now, it's not just kind of neuroimaging correlates that we're seeing in placebo effect. The level of scientific evidence is actually very, very robust. So there's these blocking studies that have been done where they actually show that you can block placebo effects with naloxone, similar to the way you block an opioid analgesic drug, because guess what? The opioid-based endogenous neurotransmitter system is involved in placebo effects. So you can actually block these effects. It's not just the opioid effect. There's multiple neurotransmitter systems involved. But really, this is quite impressive work that's been done. There's dose-response relationships. Again, I'm kind of preaching to the folks in the back that might be really kind of focused on the level of evidence here. This is quite robust work that's been done. We see that you can augment the placebo response. So basically, there's a stepwise fashion here from basically no treatment, so no placebo response, to a sham acupuncture device, to a sham acupuncture device augmented by warmth and positive kind of patient-physician relationship variables. And you see this this nice increment as we like to see when we're studying other topics in medicine. And probably the most robust area of evidence comes out from knockout models. And again, I use these terms, reflective of kind of the scientific rigor that we like to see, especially, in the basic science. But what happens when we get rid of placebo effects in clinical settings? So this is really nice work that's been done around the world, but especially by Dr. Benedetti in Italy. And they basically looked at paradigms where instead of having that usual clinical interaction associated with, for example, getting a painkiller, they would have a kind of a computer giving you the exact same dose of a painkiller at random times. So you didn't have the expectation and all of the cues in the environment and all the positive expectations that come with that of getting the painkiller, but it's the exact same painkiller given. And what do you see? Well, you see you lose almost half the effect of the painkiller just by losing the placebo effects. And you can do other ways of tackling this topic. You can basically give patients a placebo, but tell them that they're you can tell people that they're getting a placebo, so the saline group here, but they're actually getting the true fentanyl-based painkiller. But they've lost the expectation because you told them you're giving a placebo. And what happens there? They're getting the exact same thing. Without the expectation, you lose a bunch of the effect. In the clinical realms, probably the best study of this nature was done in migraine by the group at Boston Children's and Harvard. Really complicated study, but just want to focus in on two of these data points. So what they did was they took triptan medications and played a game of shuffling the labels on the bottles. And so this contrast, which I'm showing you here, is a contrast between real triptan labeled as placebo and then placebo labeled as real triptan. And they actually saw no significant difference between those two groups. One is all placebo effect, one is all triptan effect. And anyways, you can see how important this is in medicine. So shifting gears, what's driving these pretty amazing effects that we're seeing? That gets a lot more complicated. There's a lot of different models that have been proposed. This is a nice read on the topic in New England a few years ago. Most of it boils down to expectancies, and expectancies can be both conscious and unconscious and acquired in a number of different ways. One of which is what your previous experience is with the given treatment, what you've learned about that treatment. And this comes down to some basic classical conditioning. We all remember Pavlov's dog. Well, in the medical context, you're a patient, doctor comes by, hangs a bag of morphine, your pain goes down. Day 2 post-op, let's say, same thing happens. Day 3, same thing happens. Well, day 4, you're part of a research study, and they hang saline instead, but you're expecting to get the morphine unbalanced you at saline, and your pain still goes down even though you didn't get the pain-killing drug. That's kind of the principle of this learning and previous expectation. You can also have expectancies generated through suggestions or verbal instructions, like someone you trust, a physician, or otherwise telling you what this substance will do or what they expect to see. You can learn socially. There's, in the psychological realm, there have been many interesting studies of kind of actors in the waiting room and kind of shaping responses to a treatment that you might receive based on the response that they're telling you as you're waiting to get it. And certainly this is seen across the world in many social phenomena that we'll talk about later. Before I'm done kind of this intro bit, I can't leave out definition of nocebo effects, but this is really not what we're covering here. This could be a whole topic unto itself and a whole presentation unto itself. Maybe at a later date and in a later year, I can give the justice that this topic is due. Also, this topic is the usual one that gets me into trouble, so it'll be nice to kind of leave it off the table for today. But this is kind of an inverse effect where you can have new or worsening symptoms in response to negative expectation. And most of this data comes from the randomized controlled trials, where we have this huge body of evidence from patients who have been given placebo in a randomized trial, but at informed consent are told to potentially expect these side effects that you would do at informed consent for a given treatment. And they experience the side effects at a much higher level than you expect than the general population, even though they just got placebo. And so there's many great examples of this. I'm not going to get into it in detail here as I described. If you want kind of an interesting population experiment series of studies, then look no further than the work here done on wind turbines and infrasound. Just a fascinating body of literature. Again, there's biological mechanisms underlying nocebo effects, and it's just something that I want to throw out there, but I don't have time to talk about today. So I hope that that was thought-provoking and that I've convinced you in some way that this is an important kind of biologically based phenomena that we need to start thinking about in medicine and research more. And so in medicine, really where I want to start is the fact that the two major considerations for factors that influence placebo effects are the patient and the treatment, obviously. And we'll start with the patient. And it's extremely important to emphasize that this is not something where I'm some wacky person thinking that placebo is going to cure all illnesses and maladies, you know, from acute infections to cancer to heart disease. No, that's not the case at all. But you know, sometimes there can be misconceptions. So I just want to make sure that people realize that that is not what I'm getting at here. But for certain patient populations, many of which have been studied already, and many of which the common point is the brain, because that's where placebo effects act, and there are many disorders of the brain. And guess what? The brain is connected through the autonomic nervous system, through neuroimmune, neuroendocrine axes to involve a lot of the body, but there are certain brain-based disorders where placebo effects are particularly interesting. And I'm going to give a few case examples which highlight that. So the case example one are functional neurological disorders or brain disorders. And I became really interested in this topic. And I know you've had some really good talks already before me on this, the evolving area, which is this fascinating field. I was really frustrated with seeing how these patients were kind of circling through the healthcare system, often dismissed and neglected. And, you know, really surprising to me, this kind of piece resonated with a lot of people and ended up gaining a lot of traction, both in social and lay media, and was the journal's top article of the year just before the kind of the pandemic hit. But we really got a good conversation going. And I've continued to have a particular interest in that patient population. And so the intersection between that and placebo effects is near and dear to my heart. And really, this is near and dear to all of medicine's heart, because it's one of the oldest examples of a placebo-controlled trial, one of the oldest examples of placebo effects to date, going back to Mesmer and mesmerism, where patients who would back then would maybe be labeled as having hysteria had some benefits regarding placebo effects, it turned out to be. But there is so much more to this dark history than, you know, mystic trickery. It has to do with the brain. It has to do with the fact that when we look at the areas of the brain involved in functional neurological disorder and other neuropsychiatric disorders, and then we look at the areas of the brain that placebo effects change, well, sometimes there's going to be an overlap, and there's going to be a mechanism for how placebo effects can change brain circuits relevant to disease states. And so for just pure simplicity example, if you have a disease state where the amygdala is on hyperdrive, and that might be abnormally connected to other brain regions, well, if placebo effect is decreasing that activity along that stress response amygdala pathway, well, that's a pretty good reason for why symptoms might improve in a mechanism-based fashion. And so, you know, we've had calls to increase research on this topic in a kind of new Renaissance way. And I believe you already had a talk related to this study and this, you know, really nice work looking at beyond kind of shared neuroimaging models to really some of the core predictive coding models that might be happening in the brain could explain some of the effects here. Case example two is Parkinson's disease, and there's some of the most robust literature out there on placebo effects in the Parkinson's disease patient population. And so in patients with Parkinson's disease, they have a dopamine deficit because their brain has degenerated in areas that produce dopamine, like the substantia nigra. And lo and behold, we see that they're exquisitely placebo responsive because placebo effects activate reward centers and release dopamine. So again, it has to do with this shared neurobiology rather than, oh, this disorder is fake or that disorder is not real, and it is all about the brain. It's not about something being fake or not real. And this example really hammers it home, I think. And then looking more broadly, because placebo effects are clearly relevant across all of medicine, this paper is really, really fascinating. It was a placebo-focused paper, one of the only big placebo-focused papers getting the attention of the New England Journal of Medicine. They had 4 arms: your active albuterol treatment for asthma, sham inhaler, sham acupuncture, so a second placebo group versus no intervention. And they had 2 outcomes. One, they were looking at your objective spirometry, FEV1 assessments in asthma. And then 2, they were looking at the subjective response of the shortness of breath. So what did they find? Well, they saw that on FEV1, there was really no, this is their objective marker, no placebo effect. And so if you just see this chart, you say, wow, in asthma, there's no placebo effect. There's no, difference between placebo and the no intervention control. And the albuterol is a really effective drug. But then if you just shift that outcome measure to the subjective outcome measure, shortness of breath, you see the exact inverse. You see the exact opposite, where you see, oh my gosh, there's no effect of albuterol really against placebo on patients' shortness of breath. And so this led to a lot of questions. Well, which measure is the more important one? And a lot of other questions about objective, subjective symptoms. And this is an ongoing discussion and important topic for the field. But just to highlight that this really does impact all of medicine, and it also impacts the way you're designing research studies, what type of outcomes you're using, etc. Beyond specific patient groups, there is clearly more heterogeneity at the patient level. There are genetic factors that influence the enzymes that are involved in the breakdown of neurotransmitters that might be involved in placebo effects. That's clear, just like any disorder or phenomena. There was a recent look at personality, which is another factor that's been studied a lot. This was just published, I believe, a week or 2 ago. And it basically said there's no convincing evidence to date to suggest that a particular personality style would make you more or less responsive to placebo. Those are a really important topic of the field. I think there's still some more nuanced work to be done here, but it's not as obvious as you think when you're thinking of optimism and things like that. So obviously beyond the patient and interacting with the patient as a treatment itself. And there are many factors that influence placebo effect on the treatment side. This fascinating study of hypertension, one of the first big kind of randomized controlled trials, 4 arms, IV antihypertensive drug, oral antihypertensive drug, oral inert pill, and then IV saline, so 2 placebo groups. And one of their surprising results, which they weren't expecting to see, was that when you looked at the 2 placebo groups, the inert pill versus the IV saline, they actually found that the IV saline lowered the blood pressure more than the inert pill placebo. And so you see that with these blood pressure reductions here with the parenteral, which would be the IV. Really fascinating stuff. And when we look at kind of this topic of treatment intensiveness, there's nothing more intensive than kind of a surgical treatment or procedure-based treatment. And so in surgical placebo controls, sometimes they do, pretty elaborate stuff where they'll do, the sham group will get a superficial skin incision, they'll get, the draping, the anesthesia, the cleaning, all that type of stuff, but then they'll do the incision, but they won't touch the target organ. But you can imagine a very elaborate setup. And on almost all of the surgical sham controlled studies that have been done, they show enormous placebo effects and no difference really from the active treatment. So, you're getting a tour of the New England Journal's kind of stationery over the past, many years. And you see all of these studies that show these huge, robust responses, and so much so that it's rare to find these sham-controlled surgical trials now. There were a couple of big ones published in The Lancet recently that again drew some attention to this field, but the commonalities are the same. These are intensive procedures that are showing huge placebo responses and really changing the way people view how important that is on things we take for granted that work, like PCI for stable angina. So again, this just echoes what I've said, that this seems to be a very important variable. The thing that's frustrating in reading a lot of these studies, as I've done kind of some deep dive into the literature, is that often, these are very different procedures, very different kind of surgical treatments with very different sham controls, yet often the conclusions from the authors is, oh, there must have been something about that sham control. There's no way these patients got this better. That's impossible. So they all, even like there was huge literature on, the cytokine effects that can happen from a superficial skin incision and not touching anything. It's truly remarkable. Whereas there is a much simpler explanation that could be that, wow, these placebo effects are real and really modifying outcomes in a way that we need to take more seriously. There's obviously other factors other than treatment intensiveness. There's things like cost, innovation, branding, a whole host of different factors. This study in Parkinson's disease emphasized this point of cost. Patients were either given an expensive, fast-acting new dopamine agonist treatment or a cheap one. That's really the contrast here, and you see this amazing difference. And again, every patient is just given placebo in this study, and the effect you're seeing is from the cost associated with it. The clinician also holds a lot to the treatment encounter. I won't go into details of these studies, but basically a competent and warm physician equals larger placebo effects. That's not a surprise here, but it kind of goes deeper than that. And there's some recent work by this group looking at deeper factors. And if you look back to the kind of the picture that I had on my last page, when you look at what a smart doctor looks like, well, the first hit is this old white male doctor. And they showed pretty interestingly that placebo effects in a clinical setting might be larger from things like gender, male doctors, as well as they found that Black doctors had lower placebo effects than Asian and white doctors. So these are very controversial, complex issues. There's a nice piece in Vice summarizing this trial. I gave some input on some of the factors here. But suffice to say, many levels of the patient physician clinician interaction matter, some of which can be controlled and some of which can't be controlled, and really much more work needed here. So when we look now at research, for those in the room that might have this more of a focus, we need to make sure we're all on the same page with the terminology, because placebo response and placebo effects are not the same thing. So in your typical placebo-controlled trial, an active group and your placebo group, you want to show this difference between the two. That placebo group, it's not just placebo effects, what I've talked about so far. There's also other effects that go into that. There's regression to the mean, there's spontaneous improvement, there's Hawthorne effect, just the act of being observed in a clinical trial setting. There's elevation bias, there's other factors that we might not understand. And so the sum of those effects in that placebo group in a trial, that's the overall placebo response, which really, if we're looking at how to break that apart from placebo effects, you need a no treatment control that would take into account most of those other effects, like time, et cetera. And unfortunately in medicine, we rarely have these no treatment controls, and they're also imperfect. But this is just to make sure we're all talking the same thing and using the same terminology. And also, obviously, important to mention that the active group isn't just mysteriously all amazing specific effect. It's made up of those same factors, plus possibly some specific effect. So I've done a lot of work on this topic of challenges to the conventional framework of how we view placebo effects in clinical research. And as I mentioned, kind of the origins of this all started with brain stimulation. And I won't go into all of the factors we discuss in this paper, but this is kind of a nice thought-provoking schematics that I'm about to show, as we are having huge growth in this field of neuromodulation and brain stimulation technologies. So let's take an example of a conventional pill-based pharmaceutical trial. Let's say that there's these large specific effects seen in this large study, relatively modest placebo effects. And if this was shown to be significant in a large trial and maybe replicated, well, you get FDA and other regulatory approvals, and everybody would be hunky-dory. Let's take example B, where we have a device which has very large placebo effects and a more modest specific effect. Unless you had thousands of patients, this would almost certainly be a non-significant difference. No trial. Regulators would say, no, this device is not going to be approved. But if you were to look at these two treatments for overall patient improvement, which is what as clinicians we think we care about the most, maybe, well, we see that it would be pretty hard to make the argument that device B wouldn't make patients as good as drug A based on their symptoms on this chart, especially if we talked about the fact that placebo effects might be biologically based. We can maybe take away some of these categories, and at least you couldn't say that drug A is clearly much better if again all you're caring about is overall absolute improvement in patient symptoms. What happens if drug A doesn't exist, or if drug A has a lot of side effects? Again, these are very important ethical, philosophical questions, thought-provoking questions. I'm not saying there's an easy answer here, but that's something we need to think about, the disease impacts of the differential placebo effect. Another thing we need to think about more is looking at what if there's this shared neurobiology between your treatment and placebo effects. And this was some work that was recently published in Molecular Psychiatry. And the 5-second overview of the study is we did a really large neuroimaging meta-analysis showing brain regions that change with placebo effects across patients and controls. And then treatments, and it's easier to use targeted treatments like TMS for depression, change areas of the brain that overlap with the areas that placebo effects modulate. And so what are the implications of that? Well, if we were to have the first example here, where we assume that your treatment and placebo effects have no overlap in therapeutic mechanism, clean cut between placebo and treatment effects, then when we get into these issues of increasing placebo effects, it actually doesn't matter at all, because you're adding placebo effects equally to both groups, right? And you're preserving that ability to see a difference between the active and placebo group, right? The issue comes in examples like neuromodulation for depression and many other depression treatments and many other treatments in neurology and psychiatry, where there is probably a shared therapeutic mechanism between your active and placebo group, the activation of the dorsolateral prefrontal cortex. And now we have this kind of divided area of overlapping effects. And then when placebo effects grow in a kind of a hypothetical example, you now see that you lose your ability to detect the difference between the two groups. So for example, if the placebo effects are really high and maximally stimulating that DLPFC circuit, and your treatment activates that DLPFC circuit, well, there might not be any room left for your treatment to work. It's almost like a Stolen effect phenomena. It doesn't mean the treatment doesn't work. These are really critical issues that we need to take into account. The last major issue we need to talk about when it comes to research, and again, this is just the tip of the iceberg, but is the issues of blinding integrity, which goes hand in hand with placebo effects. So interestingly, as part of the consort guidelines, you don't have to collect information on blinding integrity. The whole story behind this, some of the people behind the decision felt that, these patients are going on hunches, and anyways, lots of variables and external factors that probably influence the decision. But this has really been brought into the spotlight recently with treatments that clearly are hard to blind. And so in these two huge high-profile psychedelic trials, including psilocybin and MDMA, they either didn't check to see if patients were actually blinded in their supposedly kind of double-blind studies, or they did kind of, and almost 90% of patients knew what they were getting or were basically unblinded. And I remember reading in the New York Times a write-up on this recent MDMA trial, and I couldn't even believe reading this sentence in the New York Times saying, Most participants guessed whether they were receiving placebo or MDMA. This did not undermine the study's results or its methodology, even though that would undermine the exact basis of these trials per se. And it was actually agreed to in advance by the FDA. And that was kind of another hold the phone moment for me, where I was like, wow, that is a really, really interesting thing to see. And so we wrote kind of to Nature Medicine and had this nice piece published about the concerns that we see in regards to this. And I wouldn't have time to talk about it in more detail, but I would highly recommend checking it out if you haven't seen it yet. And so really what it comes down to is the blinding is critical to have an equal distribution of placebo effects between groups. That's what we're hoping for. Equal expectancy. You don't really know what you're getting, placebo or active treatment. And for many pharmaceutical trials, that's really easy because you're just getting a pill at home and it doesn't work right away. And so, it's preserved. Not all the time, but sometimes. Well, getting a psychedelic, which is acutely causing psychoactive effects versus a placebo, it's clear that there's going to be unblinding. And so in many of the papers that I just highlighted, these paper, they usually have a line like this: blinding was challenging and possibly led to expectation effect. And you may have seen this kind of meme going around Twitter. And maybe this is a bit much, but it really hammers home that yes, this is a huge, huge, huge issue. What happens is that group gets a whole bunch of placebo effects because they know that they're getting the treatment. They know that they're in the active group. That's what they wanted. That's what they signed up for. They're probably also getting some specific psychedelic effects. I want to make it clear here that I do think there are specific psychedelic effects. This is a very important avenue of ongoing research that has a lot of potential. And we're just scratching the surface of as well. But with these study designs alone, even if there was no specific psychedelic effects, you would still see a big difference between the groups based on this unequal distribution of the placebo effects. Because that group that knows that they're probably not getting psychedelics, they don't really feel much, they're not getting that acute experience, they would have very low placebo effects and possibly even nocebo effects from saying, oh, the heck, I wasted all my time signing up for this trial, all these things, and I'm not even getting the drug. So how do we move forward? I'm kind of keeping a rough eye on time, and I appreciate one of the benefits of presenting virtually is that I'm not having someone there stand up and kind of tap the microphone or anything like that, but I do want to leave time for questions, so I'm gonna go through this last section somewhat quickly, and this is often a topic that is discussed further in a Q&A after anyways. How do we take this, and especially with a clinical lens, how do we take this information that I presented and move forward with it? Well, obviously one of the critical things is to get away from the idea of this being a nuisance, something we need to avoid, to something we need to interrogate as new kind of potential treatment and otherwise and clinical implications. And so when you look at the literature about how to kind of leverage or harness placebo effects, there's really three ways here. You can, and kind of an order of kind of least ethically concerning. So with extracting the principles of placebo effects, there's really nothing wrong with that. Some people might make that akin to, a good patient-physician relationship, one that's, fostered in trust and a good therapeutic alliance. And, I kind of would refer to it as the art of delivering placebo effect without the placebo. And there's a lot of shared principles between this and good psychotherapy techniques, where you can really change mindsets, change expectations, get someone to believe, again, that they can get better. This is very important in clinical interaction. So kind of injecting the science of placebo effect into your clinical interactions, because you know that that's going to benefit your patient, can be helpful. Then there's been some growing work about honestly delivered placebo. So giving placebo open, where you tell them it's a placebo, it would kind of violate some of the principles that we think underlie placebo effects, like positive expectation, etc. But there may be complex ways in the brain, because hey, the brain's really complicated, in which this might still work. I still, have some reservations about this growing field, but you can't lie with some of the data. But it's still to be determined how useful this could be. And then there's what we conventionally consider placebo, which is kind of deceptive in nature. And there's two levels to this, a pure placebo and then an impure placebo, where the impure placebo would be something that doesn't necessarily have any clear evidence-based ingredients that would be helpful for the condition, but is not completely inert. So vitamins or low doses of certain medications. And interestingly, in reviewing a lot of the literature on this topic, I was really surprised to see in this big study of U.S. Internal medicine doctors that most patients and most physicians believed it was okay to recommend treatment to primarily promote a patient's expectation. Permissible, 59%, and permissible in rare circumstances, 31%. That was really shocking to me to see. And many physicians are doing this, whether they are doing it knowingly or not. And it gets really complicated. Is that ethical to do? Is it ethical to prescribe or to suggest some, treatment when you think that the major route is via placebo effects? There's been cases either way. You could defend yourself by thinking, well, this treatment works through various networks in the brain, and it is, it has a specific effect for certain disorders. And that's really what it comes down to here, because in most medical associations, they are pretty, and importantly, against deceptive use, the harms, and they define placebo as usually something with a specific pharmacologic effect. And so you can make arguments about maybe for certain cases there is kind of this specific effect on the brain. It modulates the circuits that we care about. But it gets really, really complicated, as you can imagine. And we did a deep dive in terms of more the practical ethical issues in a neuropsychiatric population with myself and Sarah Listone on this topic. We present a case who was given kind of saline injections for a functional movement disorder. Anyways, you can read more about it, but the patient got better. But once they found out they were given placebo, kind of completely ruined the therapeutic alliance, and they didn't come back to the clinic. And that's a vignette that's used as on this whole chapter where we go back and forth about some of the pros and cons. So obviously don't have time to get into all that here, but this is a kind of a practical guide that could be applied to different topics. So what are we doing in the meantime? What's happening in the real time when we're deciding how or if it's ethical to study this in medicine? Well, there's a lot of real world data that's being collected out there right now, whether we want to admit it or talk about it or not. There's huge booming wellness and other alternative industries where when you look at the disorders that they're targeting, either kind of quote unquote many placebo responsive symptoms, pain, fatigue, mood, etc., and you see lots of the marketing very akin to the textbook on placebo effects, these high price points, pills that look like gemstones, derived from all these different places. And I did this piece with CNN. I was worried I was going to get sued by Goop, to be honest, because I said that, yeah, this is probably working through placebo effect. But much to my shock, their kind of official response from the chief content officer was, if it's a placebo effect, that's great too, which I was just absolutely shocked to see. And again, speaks to how much we need to think about this more. Anyway, I could go on for this, but I'm not. It was just quite an interesting response, and I obviously respect them for that response, needless to say. There's huge controversial topics here, and I know that homeopathy is another topic that I think is still particularly debated in Europe, where again, similar issues where certain people might believe that this is something that will be healing. And that's what we also need to understand, is placebo effects aren't the same for everybody. Somebody needs to go to that Ivy League institution and have that old white man in his white coat give them the latest greatest treatment. Some people are going to get placebo effects from, some bohemian clinic that's offering alternative treatments because that's what they believe is actually going to get them better. So there's this huge wide spectrum, and it's very complicated to discern. But what you need to be aware of is that this is happening in almost every neuropsychiatric condition. TBI is another big field that I'm involved with. I direct our hospital's clinic, and we see these booming industries that a lot of concern about placebo effects. And so talked about this case in the US of this chiropractor offering all these treatments that were likely generating their benefits from placebo effects potentially. And Brian Bernstein did some great investigative journalism on this. There's NHL players going to see this chiropractor, and they're charging $6,000 for these treatments. And what are the ethics here? Well, the people are getting better; they keep on going back. Well, they're getting robbed at $6,000. Well, maybe you need that expensive price point for the placebo effect. You can see how all of these complicated factors are unfolding between our eyes. So we need to study this more, and we need to, have safeguards and interrogate empirically these issues. And to do that, we really need to, involve mainstream medicine, mainstream science more in these issues, and really kind of have a paradigm shift on how we view this topic. So I wanted to leave time for questions. I hope I have. I think I'm overlapping with lunch. I'm going to be joining you for a live Q&A session now. And so I can stay for longer than the time I've allotted, but I'd be happy to answer any questions now. Okay?
Thank you so much, Matt, and for joining us early in the morning and for that brilliant pre-recorded lecture. I was just talking with Johannes about how hard I find it to do pre-recorded lectures and how wooden I come across, I think, but you managed to be engaging, humorous, and deliver almost as good as the real thing, or probably, so it's really impressive. Thank you so much. I was just going to say to the tech people, the iPad seems to have run out of juice that's got all the online talks, or the online questions. So I don't know if anyone can replace it. But if not, sorry to everyone online. In the meantime, good for us in the audience. We can ask all the questions. So there's a hand up from Nick Medford, I can see.
Thanks very much for that excellent talk and very thought-provoking. I guess it's fair to say that there are some medical scenarios that are sort of beyond the reach of placebo effects. I mean, correct me if I'm wrong, but I don't think there's any evidence for placebo effects in, say, acute leukemia or, catastrophic, life-threatening illness. Probably no one's ever tried to give a placebo in that situation, but, why would you? But at the same time, you showed quite convincingly that there is evidence in some, serious chronic disorders like stroke and Parkinson's disease. Now, in one way, I guess that seemed kind of intuitively obvious that there are some situations where placebos aren't going to work. But at the same time, if you're actually trying to delineate a pathway or a mechanism by which they work, then it's quite interesting to think about situations where they don't work, it seems to me. And I just wondered if you had any thoughts about that.
Yeah, absolutely. This is a great question. I just want to make sure everybody can hear me there.
Yeah.
Excellent. So, whenever I do any work with, especially with any lay media on this topic, I make it quite clear from the beginning that I don't see kind of placebo effects as a cure-all for everything, including many of the examples you gave, acute medical illnesses, like a bacterial infection or, an acute MI or cancer or whatnot. But where exactly that line is that divides things that would potentially benefit from placebo effects or conditions that from those that don't is quite blurry, because as you may have heard in the talk, really, I think the crux is if the disorder overlaps or the pathophysiology of the disorder involves the brain-body circuits that placebo effects can modulate, then there's going to be some placebo responsiveness. And the brain obviously controls much of the body. And so I think that it's probably, a wider net than we think. But, how to exactly determine this? Well, we have to look at some of the clinical trials, and would be a huge amount of work. It wouldn't be impossible, but you'd really have to look at a lot of the clinical trials across some of the other fields that you mentioned, because they do placebo controlled trials as well. And you can see the magnitude of the placebo response in some of those fields. And my guess is many of the fields that you discussed that probably wouldn't be as placebo responsive, you're not going to see the 30-40% response rates that we see in some of the clinical neurosciences. But this is a great question, and especially one to emphasize, because thoughts that placebos are going to cure many of the acute medical illnesses is a big problem and kind of an almost an anti-science problem in many ways in society right now. So we have to make it clear that there are lines here.
Great, thank you, Matt. There's a question just here with the guy with the mic, and then Hugh next. If the
Richard Tilly, a clinician, psychiatrist. My question is specifically about, you speak about the crossover between, for example, in Parkinson's disease, the neurotransmitter stimulated in placebo and stimulated in given Parkinson's drugs. Does that happen in people who've never been given Parkinson's drugs before, or is it only in people who've previously been exposed? The reason I ask the question is because in the opiates, we know they're previously exposed to opiates, and then they get a placebo and they get a desired response.
Yeah, I'm not 100% sure the answer to that question. My guess is that it might not matter as long as they have the therapeutic expectation that this is the drug that's going to help my Parkinson's disease, in terms of, they're told that they're going to get levodopa and they expect that that's the right treatment for them. And they're given placebo, and the placebo will induce that activation of the reward centers and release dopamine. Obviously, I think the effect would probably be stronger if there's been some existing conditioning and learning and, in the brain already from receiving levodopa previously and getting a response. I think that would strengthen it, but I don't know if naive patients would be completely responsive.
Thanks, Matt. So, Hugh.
Hello there. Hi, my dad was in medical school in the 1950s, and in his pharmacology textbook, there was a special chapter, and it was called The Correct Administration of the Placebo, when it was basically an instruction about how to give placebos to the best effect. Do you think we'll be going to be getting those chapters back in our medical textbooks again?
Well, I think that really one of the biggest issues is that, except for back then in those chapters, this isn't a topic that is taught in medical schools or is taught, rigorously in research training programs. I know in my medical school training, I didn't get a single lecture really on this, and in all of our critical appraisal of the literature, talks and workshops that we do throughout our career, never have I really seen much attention to, okay, let's look and interrogate that placebo arm and let's see what that response looks like. And is that really, we just don't have that. So obviously I hope that with this increasing, really nice data that we're seeing, that is injected more into our training, because I think it is important. It's been a neglected topic. And, I think based on our current understanding of the science, there's no excuse for it to be kind of neglected anymore.
Great, thank you. So final question from Jan. Sorry, online people, I couldn't see your questions, but final question before we break for lunch from Jan.
Thank you. Great talk. In the Parkinson's, actually, it is in naive patients, and the effect is maintained for 6 months. So that's really interesting. My question was, is there anything on reverse nocebo? So often when I try to withdraw people from opiates or diazepam, I talk about the side effects they might be having, and that coming off, they might feel better. Is there anything on that in literature of that reverse nocebo kind of has a therapeutic effect?
So this is a really, really important topic, and I didn't touch much on nocebo effects just because there wasn't any time really. But I think one of the other, important thought-provoking pieces of how we can leverage this is what you describe, and that's trying to mitigate, or as you describe, reverse the potential nocebo effects with kind of positive expectation in the other direction. And I think that this is a really important thing to really consider, and similar to the way that you would describe potential side effects when starting a patient on a medication, especially if you're working with a neuropsychiatric population, whether it be FND or chronic pain or another disorder where you know that they might be sensitive to medication side effects, how you describe that. Do you even include many of the potential side effects because you're worried about creating nocebo effects? From that, where is the line of ethics for informed consent versus trying to mitigate harm from nocebo effects, which is really real harm because not only might they experience side effects, but they often discontinue the medications fairly abruptly, medications that could be helpful for them. So this is a really important line of thought. And I just want to say there on the last topic, because I think this is the last question, I just want to thank the technical team there. There was one of the technicians who was staying on with me as I talked, so I had some kind of firsthand reaction. So Tim, maybe that helped kind of give a more animated talk. And so thanks to the team, and I'm sorry I couldn't be there in person.
Thank you so much, Matt, and once again, thanks for an amazing talk, and hopefully we can get you back in person to talk about nocebo at some point. So thank you, Matt, again. Thank you.